Okay, this is the first of a series of lectures that we intend to give as part of the initiative taken by the Indian Society of Critical Care Nursing to improve the level of care provided to the nurses. And that can be only done by increased knowledge and increase in the medium of communication between the doctors and the nurses, because you have to accept that the thinking process of the nurses and the thinking process of us as doctors are sometimes going at parallel. They are not in tandem to each other, and that is why we should understand the specific attention that the nurses give to various things, and maybe divert our thought process in such a way that we start thinking the way they are thinking, and then only we can communicate better, and then and only then they can implement what you intend to do in your patients. So this is the first lecture where I wish to talk about how is critical care nursing different from general nursing. And you would accept that the kind of training that the nurses have, whether it is diploma nursing or whether it is BSc nursing, somehow or other, the kind of training that they have right now, as of now, they are not somehow or other tuned to look after critically ill patients, and they are not tuned to the thinking process that we have. And when we look after our patients in the intensive care unit, we take the nurses as part of a team, and that is a big hurdle for the nurses to cross. So the first and the foremost thing that we as doctors need to do is to allow them or empower them to actually talk to us at the same level, and that is a bit of that needs a bit of a doing. And that is, I'm sure people like Deepak Govil and Susru Bandyopadhyay, they have taken years in which they have developed that kind of confidence in the nurses to be able to talk back to the nurse, to the doctors, and maybe even make suggestions that this is the central line has been put 10 days back, the antibiotics have been continuing for 10 days. These small kind of things that sometimes they are very hesitant to speak about. And this is the change in the mindset that the nurses need to undergo, to sort of sometimes even question the actions of the doctors that are looking after the patient, or suggest them a particular mode of action, because she must have seen, or he or she must have seen, that that particular thing works better in a given set of circumstances. So this is the empowerment of the nurses to talk to you as on the same level. That is perhaps the biggest paradigm shift that the nurses have to make when they come from the wards or they come fresh from their training, and then they enter into the intensive care unit environment. So we start with what is critical care medicine. And now every hospital, when I was doing my training in critical care, if I would have had 600-bed hospital, the number of ICU beds would be six. That is roughly 1% of the total ICU beds. And now, if you look at the hospitals that are mushrooming in every part of the country, on an average, there could be more, but there could be less, but on an average, the number of ICU beds are 10% of the total bed strength of the hospital. So we have gone up from, let us say, 6 beds to, in the same 600-bed hospital, to 60 beds. And obviously, when we are looking after 60 critically ill patients, then the numbers, the requirement of the healthcare personnel, whether it is doctors, whether it is nurses, or whether it is paramedical staff, the physiotherapist, and all the people who work in the intensive care unit, the numbers have to go up. And those numbers not only need to go up, because we have realized from the pandemic that we are facing right now, that the numbers don't mean anything unless the skills are there to look after the patients. So critical care medicine has now become an integral part of modern healthcare systems, and all hospitals all over the world are increasing the bed strength in the intensive care unit, because by and large all of us have come to realize that hospital is an expensive proposition. Hospital sickness and as hospital admission is a very, very expensive proposition. And that is why we need to admit only those patients who are sickest. More often than not, we tend to look after them on a daycare basis. They come in the morning, leave in the evening, or maybe at the most next day morning. So by and large, the doctors try to manage the patients on a daycare basis, on an outpatient basis. But then there are occasions when they have no choice but to admit the patient in the hospital. So by default, we are choosing out sicker patients to admit into the intensive care unit. And if the entire hospital is full of sicker patients, it is no scientific uh, rocket science to actually say that from the sicker patients, quite a few of them would need critical care facilities. And that is why the demand for critical care nurses, the demand for critical practitioners, and all the people who are allied to critical care, that demand is going to increase exponentially. So all of you who are listening to me, and if they want critical care medicine to become their specialty, then the demand is huge, and the skill sets that we have at the moment are not enough. And that is where the Indian Society of Critical Care Medicine is taking this initiative to impart more educations as a part of the skill development program among the nurses, with the ultimate aim of improving the care to the critical care patients. But then there are major differences in managing patients either in the ward or in the intensive care unit. We are dealing with patients who have got greater severity of illness, and there is more immediate risk of death. The sword of Damocles of death is actually hanging upon you, and that is why the level of uh, stress that you undergo perhaps is slightly more than what you would perhaps be exposed to in the general ward. And then in the general ward, you must have noticed, we don't put central lines, we don't put PA catheters, we don't do lots of things that we do in the intensive care unit. Why do we do so? For this simple reason that we are dealing with a patient who is likely to die. So in the scale, when the death becomes a major possibility on one side of the scale, then any intervention, however much the risk would be, those interventions become justified. And that is why you would see so many interventions being done in the intensive care unit. And all these interventions, the reason they are not done in the general ward or other places, not that we don't have the skill set to do it, but because they have a finite risk. And that is why the interventions are kept to as minimum as possible. Since we do these interventions in the intensive care unit, since the nurses help us in doing these interventions in the intensive care unit, the chances of complications from these interventions are also very high. And that's why we have to deal with those interventions. But at the end of the day, interventions are best dealt when they're recognized early. And since the nurses are at the bedside of the patient all the time, if we uh, skill them enough to identify these complications earlier, then obviously everybody is happy. And most importantly, the chance of that intervention led complications to progress further into deterioration of the patient condition is perhaps avoided. And that is why the nurses have to be skilled enough to identify these interventions. But then over the years, what has happened, and I would probably share this experience with the senior nurses who are listening to me, that there are apparent conflicting expectations between the hospital management, the doctors, and the nurses. The hospital management always say that the available resources are limited, and that is why we have to ration the amount of resources that we spend in various parts of the hospital. But on the other hand, we are the ones, including you and the nurses and everybody, they are the ones who confront the relations of the patients who come at the bedside. And then they see that from the corner of the angle of the mouth, some blood is coming out. And they would see that the patient's blanket has not been put on him. And then they start creating a fuss, saying that we are paying such a lot of money to you. Why can't you even provide this kind of care? And for providing that kind of care, the nurses demand that we should be given this, we should be given that, and we should be given. That will make it easier for us to provide the expectations that the people have when they are spending a fortune to allow the treatment of the patient in the intensive care unit. These resources that the nurses think are genuine and unexpected in this present world, these expectations are sometimes not met by the management, because again, the management is limited by the limited availability of resources and the expectations of the other part of the hospitals. And then quite obvious, there are other parts of the hospital which are probably generating more revenue, and that's why they are given more resources, and we might be giving more less revenue. So the resources have to be divided according to the principles of or the vision of the hospital, as well as the revenue generated by the hospital. So we move on. So, but however, whatever you might say, whenever intensive care units have been developed, and this, the first intensive care units of the kind that we are looking at these days, They probably started in UK way back in the 1880s, where they started initially as post-operative care, where the sick patients who have got a lot of comorbidities were operated upon. But again, at the end of the day, the care of these kind of critically ill patients revolved around the higher intensity of nursing care they would provide, because they knew that whatever they might do, they can't generate the kind of skills in the doctors to look after these patients around the clock. And that is why the concept of intensive care was based upon providing a higher intensity of nursing care, not necessarily a higher intensity of doctor care. And that is why over the years, since nurses cannot provide all the requirements of the patients, they have learned to work as a team. And this team involves the physician, the nurse, the physiotherapist, dietitians, counselor, and so many non-medical personnel who tend to look after the patients. They come and they go. They are coming on a consultation basis. So obviously they do not spend a lot of time, but then they do examine the patient, put in their inputs, and they actually give prescriptions which they expect the nurses to follow. Now, that is a big problem. A cardiologist would come in and he would prescribe a beta blocker to the patient, and the nurse would be scared to tell him that, sir, this patient is having an oral infusion. I cannot give beta blockers to the patient. And similarly, there are so many contrary things that might happen. And it is the work of the nurse to keep the patient at the center of attention, draw the attention of the concerned people to say that, I mean, some prescriptions that have been given by various subspecialties who come to see the patient, their prescription may be uh, divergent to the requirement of the patient. They would be contrary to each other, and that is why we need to have a rational approach in the management of the patient, in the prescriptions and the drugs and the delivery that we give to the patient, so that teamwork somehow or other, as the nurses grow up in the intensive care unit, they tend to develop and they manage to keep the patient at the center of their attention all the time, however many doctors are looking after after the patient. So in short, the nurses maintain the patient and their family at the center of care, with the goal to either assist the patient to recovery. And we have been working in the intensive care unit much, that we put in efforts for all our patients. We don't achieve success in all our patients. So there would be occasions in which a death is an integral part of the management of the patient, but we have to ensure that the kind of dignity that we would give to a living patient, the same kind of dignity is provided to the person who is not likely to make it, and ensure a peaceful and a dignified death. And this all is possible by effective collaboration between different members of the team. Over the years, the nursing director as well as the critical care directors have joined hands in making sure that this effective collaboration is a reality. But then this happens over a period of time with a lot of effort being given by all members of the team. So the critical care nurse has knowledge and skills. If you want to develop this kind of care pattern to be delivered to the patients, you need to have knowledge, and that cannot be provided unless you keep update your skills all the time. And these knowledge and skills are involving problem solving, critical thinking, most importantly, leadership, getting setting the example and getting work done from so many subordinates that are working under you. And at the end of the day, the team has to work, because a chain is as strong as its weakest link, and we can't allow any weak link amongst us. So that teamwork has to be maintained. And I believe that the nurses can play a huge role in making that kind of a teamwork successful, because of the empathy that they have. The same thing that I might possibly say would sound as something which is uh, uh, not polite, but the nurses would use certain language or certain words which will tone down the kind of intensity of my statement, and maybe not generate the kind of response in the other person to whom it is directed. And this is a huge empathy that the nurses tend to enjoy. And at the end of the day, India is a country where we do give respect to women in general, so they tend to tide over these so-called personality clashes that tend to happen in the intensive care unit. So the responsibilities of critical care nurses are complex and varied. They involve interpretation and evaluation of specialized information, where there's a barrage of information coming out from the monitors, from urine output to central line, the CVP, and the temperature, and the blood pressure, and so on and so forth, the endotracheal tube, whether it is in the right place or not place. So all this information has to be collated into a chart. And when it is being done so, and when they are actually doing this kind of things, they should be in a position to recognize subtle changes in patients' conditions or the output from the monitors. And if they do so, and they either they do something about it or bring it to the notice of the people who can do something about it, their job is more than done. And over the years, we have learned that in so many aspects of critical care in the patient management, the nurses have the most important role to play. And one of them is infection control, where the entire hand washing, and there were several articles which have been produced in the literature, which have shown that hand washing is more common and more commonly done by the nurses than by the doctors. So if the nurses make sure that hand washing is done by each and every person of the team, then obviously we can go a long way in infection control. Parental nutrition, again, same, it's an extension of infection control, and even enteral nutrition for that matter. All these things are completely in the domain of the nursing care. Personal hygiene and safety measures. You must have noticed that when young ladies are admitted to the intensive care unit, the nurses take a lot of pain in making sure that the hair is done properly, the lips are, I mean, the lip balm is put on the lip, and so that they are very presentable. They even do the shampoo of the hair of the patient, so at least the hair is not tied up. So these kind of things, I mean, if you ask a doctor, I mean, these things are far from his mind when he's looking after the patient, but these are equally important and that anybody would accept. So the things that have come up in the years is that nurse to patient ratio is something that the nurses script about quite a lot nowadays in every hospital. And we know that nurse to patient ratio has implications such as nosocomial infections, increased risk of infections, pressure sore incidents, falls, physical restraints, use of physical restraints. If the number of nurses are more, all these problems could be reduced. So there is a case to go in for 1:1 nursing in the critical care unit. Easier said than done. Over the last 30 years that I've been working, I have not been able to achieve that. But maybe in the years to come, we would be able to achieve that. Weaning is again something that uh, has become, at least in the advanced centers, one of the pivotal role of critical care nurse. And it has been shown in various studies that the time taken to wean patients, if the nurses are provided with a proper protocol, is less than what the junior doctors would take. And obviously, we know that if weaning is faster and the patients are taken off the ventilator sooner rather than later, then if the length of stay is decreased in the ICU, that obviously has an implications upon the cost of care that the patient would be having. So critical care nurse in a nutshell provides competent and holistic care for the critically ill patients through the integration of advanced level knowledge, skills, and most importantly, the humanist values that they are God gifted with. But this is too much of an ask that we make from our patients. And unfortunately, it is beyond the scope of the current undergraduate program that they undergo and they become nurses in the critical care unit. So what is required is a proper postgraduate or a post-registration education program. And to tell you the truth, whether it is in the government setup or in the private setup, we have yet to develop this kind of a postgraduate or post-registration program, which will cater exclusively to critical care medicine. And this is absolutely essential to achieve the depth and the breadth of clinical knowledge, skill, and humanist values to establish a therapeutic relationship with the patients. Uh, the Indian Society of Critical Care Medicine has obviously been making efforts in this direction. And if I remember correctly, the first time that I conducted a workshop for critical care nurses was way back in 2006. Dr. Manish Manjal was part of it, and Dr. Gunta organized it for the first time in Jaipur. And since then, we have been having this kind of activities over the years, every year at least. So we do a 2-day structured workshop for critical care nurses in the setting of National Conference. And since 2006, I believe every year we have managed to do it, in which we have a pre-prepared teaching material, a dedicated faculty pool. Quite a few of them are present here, and the certificate is to be given by the Indian Society of Critical Care Medicine. And then some hospitals even run 6-month certificate courses. But uh, the Indian Society of Critical Care Medicine does a IDCCN course, which is actually a 1 year course. This certificate course that I'm talking about has been prepared by various hospitals at the initiative of the local intensive care unit directors, which have something like a 6-month course in which there is 1-day contact program in which there is pre-prepared teaching material, a dedicated faculty pool. But there are 6 modules of this program. At the end of the 6 modules, they get a certificate of competence, and that can be done at the local hospital level. So the Indian Society of Critical Care Medicine has been running the IDCCN program for I don't know how many, at least 5-6 years that I can remember of. I was instrumental in getting that on the board, and I'm really glad that even after I have taken myself off from the day-to-day working of ICCM, this IDCCN post is thriving, and Susrut Bandyopadhyay needs to be congratulated for having continued with this kind of thing. And I'm sure that a lot of nurses who have actually undergone the IDCCN program would accept that the way that they look at the patients, the way that they manage the patient, and the way they involve themselves in the day-to-day management of the patient as far as the actual disease is concerned, even that has improved. So we have come a long way, but we still have a long way to go. And since the STEP program is sort of identified with the multiple choice questions, I don't know if people can unmute and answer these questions. The most important reasons for administration of sedation in the ICU: protect patients from consequences of agitation, allow the patient's body to recover from illness, reduce pulmonary complications, reduce cardiovascular complications. Any takers for this? Any audience who can unmute themselves and
Please,
answer this?
please answer. Give your answer in the chat box. Please give your answer in the chat
Chat
box.
box, yes, you can give it in the chat box. Did you get any answer, Pradeep? Because I can't see anything here.
So
Somebody has raised
somebody,
hands.
yes,
Somebody has raised hands. Just can you unmute
Punamani,
your?
Punamani, you want to answer? Put
Can
your
you
answer
unmute?
in the chat box.
Can we unmute her for a while, for a second?
Okay, lots of answer have started coming. Most of them they are answering A.
Okay. How many? 10,
Mm,
20?
yeah. I think more than that.
Great. And I'm
Uh,
sure most of them are right. The answer is to protect the patient from the consequences of agitation.
Good, very good.
Excellent. Thank
Participants.
you. We
Very
move
good.
on. Can we move on to the second question, Pradeep?
Yes, sure.
Okay. ACS stands for acute coronary syndrome. Treatment includes oxygen, aspirin, nitroglycerin, morphine, oxygen, NSA, adrenaline, morphine, oxygen, clopidogrel, sublingual nitrate, DC conversion, cardioversion, aspirin, clopidogrel, nitroglycerin, and adrenaline.
Please put your answer in the chat box.
I'll wait for a little while before I tell the right answer.
Yes. Again, people have started answering. It is
20.
A, and one has answered D. But most
How
of
many?
them
How many?
again A.
How many A's?
I think 10, 15 is one C and one D.
Yeah,
I can
most of them
say.
have got it right. The acronym is MONA: morphine, oxygen, nitroglycerin, and aspirin. MONA is the
Yeah.
right answer. So MONA is the thing that you should remember for the treatment of ACS immediately when the patient comes to the casualty, and maybe subsequently others can follow. Treatment of narrow complex tachycardia. Narrow complex tachycardia in hemodynamically unstable patient is defibrillation, cardioversion, amiodarone, BTSM. Again, Pradeep, just a
Yes.
feedback.
Waiting for the answer. People have started answering. It is started with D, A. Again, A. My answer is A. So most of them they are again answering A. Some of them they've answered B and C. But again, A, B, C. So I think there is a confusion amongst participants because many have given B, C, But again, I see there are some A's, but mostly B, C. B, C kind of thing is there
The
more.
correct answer is cardioversion. The correct answer is cardioversion. I'm afraid when you are using the defibrillator, you're using the defibrillator all right for this patient, but you have to put that mode on sync mode and then you have to cardiovert these patients. Amiodarone, I would have accepted. Sometimes we do give amiodarone for narrow complex tachycardia, but the correct answer is cardioversion in a hemodynamically unstable patients. So that's the right answer. So we move on. The following are part of fast hug protocol, except now the fast hug has been going on, increasing and increasing. They're adding so
Yes.
many things to the fast tag. I'm talking about the standard fast tag protocol, which stands only for the 4 plus 3, 7. Out of these 7 things, I have given 4, and one of them is wrong. So, which
So
one is?
most answers are D.
Yeah.
Almost all of them. There are some of them answering B. B.
So
Uh,
great. I think we have hit the jackpot this time. Temperature
hmm,
control is not part of fast tag, but I don't know in the
yes.
future, in the times to come, maybe that might be included.
Very nice, all participants. Keep it up.
Last question that is slightly difficult because quite a few nurses think that ventilation is a doctor's domain and we are not supposed to touch the ventilator. But again, as I said, you have to involve yourself in the management of the patient. You might have to take the responsibility of weaning the patient. So you should know something about the setting of the ventilator. And for lung productive ventilation, we are dealing with the patient of ARDS, for example. Tidal volume should be 10 to 12 ml per kilo, 8 to 10 ml per kilo, 6 to 8 ml per kilo, or 3 to 4 ml per kilo of predicted body weight.
So again, I can see lots of confusion. A, B, C, D. I think all answers are there. Not very consistent with one answer. Again, some C, some B, A. Somebody has answered. So I think there is a confusion.
So
Uh, mm,
the correct answer is 6 to 8 mil per kilo body weight, and that's the current
C.
standard for ARDS net protocol. Now, I'm sure that with the kind of interactions that we have had with the nurses, and even if over a chat box, the kind of expectations that we
So answer is
have,
C.
the variation, the variability in the answers have shown that yes, they are there somewhere, they're hovering there, but they're not exactly there. And that is why they need to tone up their level of knowledge in this particular field of critical care. And this is the kind of expectations that we would like to have from our nurses. And maybe if they meet these expectations, they would also derive a lot of respect from us. And once the kind of respect has come in, then it will be easier for the two of us to work as a team, because any relationship is built upon mutual trust and respect. I would come to the end of my presentations and I hand over to Pradeep Bhattacharya.